My name is Dr. Brian Quinn, and I have worked as a pathologist at Baptist Health since 1995. I am board certified in anatomic pathology, clinical pathology, and transfusion medicine, and a medical director of the blood bank at Baptist Little Rock. I am also actively involved in the blood management project here at Baptist. Earlier this year, Baptist Health Physician Partners established a multidisciplinary blood utilization quality project, and we hope that this project will contribute to improved patient care and better outcomes for the patients that we serve. As part of this project, I have put together a series of clinical presentations that are intended to update clinicians regarding the benefits of a conservative approach to blood transfusion. This presentation, which lasts approximately 12 minutes, will briefly summarize some of the scientific evidence evaluating hemoglobin thresholds for red cell transfusions, including results from two of the most widely cited randomized controlled trials that have lent support to more conservative red cell transfusion guidelines being published by expert physician panels. One of the oldest and still most influential of these trials was published in the New England Journal of Medicine in 1999. This groundbreaking study is referred to as the TRIC trial, in which TRIC stands for Transfusion Requirements in Critical Care. Although the TRIC trial is ranked by many transfusion medicine authorities as the #1 landmark study that changed transfusion practice worldwide, many physicians are not familiar with this now 15-year-old study. In this study, 838 anemic, critically ill patients were prospectively randomized into one of two treatment groups. Patients in the liberal transfusion group were transfused when their hemoglobin level dropped below 10 and were maintained at a hemoglobin level between 10 and 12, which at the time was a not uncommon approach to these challenging patients. Patients in the restrictive transfusion group were transfused when their hemoglobin level fell to below 7 and were maintained at a hemoglobin level of 7 to 9, which was somewhat of a departure from the usual practice in the 1990s. Red cells were transfused 1 unit at a time with subsequent measurement of the hemoglobin level to track the effects of the transfusion. The results of this study continue to influence transfusion practice today. The primary outcome was the mortality rate at 30 days after the ICU admission. The primary outcome measure, which was the mortality rate at 30 days after admission to the ICU, was relatively similar in both groups, 18.7% in the restrictive group and 23.3% in the liberal group, but favored the restrictive group. However, the mortality rate at 30 days was significantly lower in the restrictive group among patients less acutely ill, 9% versus 16%, and among younger patients less than 55 years old, 6% versus 13%. The mortality rate during the entire hospitalization was also significantly lower in the restrictive group, 22% compared to 28%. Finally, the restrictive strategy resulted in 54% fewer red cell units being transfused compared with the liberal group. In terms of secondary outcomes that were evaluated, there were no statistically significant differences in long-term mortality, infections, or hospital length of stay. A lower rate of myocardial infarction and congestive heart failure occurred in the restrictive group. A post hoc analysis of several subgroups of patients enrolled in the TRIC trial showed no statistically significant differences in the primary outcome measure for trauma patients, patients with moderate to severe head injury, patients on mechanical ventilation, and for the 357 patients with cardiovascular disease. In the conclusion, the authors stated that we recommend that critically ill patients receive red cell transfusions when their hemoglobin concentrations fall below 7, and that the hemoglobin concentrations should be maintained between 7 and 9. The diversity of the patients enrolled in this trial and the consistency of the results suggest that our conclusions may be generalized to most critically ill patients, with the possible exception of patients with active coronary ischemic syndromes. Although the results of this trial cannot be generalized in the patient groups that were excluded, such as patients with active hemorrhage or patients undergoing cardiothoracic surgery, the practical effect of this study has been to lower the hemoglobin threshold for transfusion to 7 for many patients. The disclaimer regarding patients with acute coronary syndromes was added by the authors because there was a slight but non-statistically significant trend toward decreased absolute survival in patients with severe ischemic heart disease who were enrolled in the restrictive group. In addition, a relatively greater proportion of patients with severe cardiac disease compared to other types of comorbid conditions had attending physicians who declined to enroll them in the study. The authors went on to say that we believe that a restrictive strategy can be implemented in patients with stable coronary artery disease as opposed to unstable active coronary syndromes. The 20th and most recent prospective randomized controlled trial studied anemic patients with acute upper GI bleeding and was published in 2013. GI bleeders as a group are a major consumer of blood products, and these patients have been specifically excluded from many trials, including the TRIC trial. There have been a few observational studies, as well as several small controlled trials that have supported the use of a restrictive approach to red cell transfusion in GI bleeders, but the recently published trial from Spain represents the largest randomized controlled trial. This single-center trial enrolled 921 patients over a 6-year time period and compared outcomes in patients who were randomly assigned to either the liberal transfusion group who received blood when their hemoglobin level fell below 9 or the restrictive group who received blood when their hemoglobin fell below 7. Red cells were administered as single units with subsequent measurement of the hemoglobin level. The protocol allowed for a transfusion to be given anytime symptoms related to anemia developed, massive bleeding occurred during follow-up, or surgical intervention was required. The primary outcome was the mortality rate at 45 days. The mortality rate was lower at 45 days in the restrictive group. In addition, the occurrence of rebleeding was lower in the restrictive group. Finally, the occurrence of adverse events such as fever, allergic reactions, circulatory overload, pulmonary edema, acute coronary syndrome, acute kidney injury, stroke, and bacterial infections was lower in the restrictive group. It should be noted that the patients were at a center that provided access to rapid endoscopic intervention when needed for the GI bleeding. The authors postulated that the increased rate of rebleeding in the liberally transfused group could be related to rebound increases in portal pressure that might precipitate portal hypertension-related bleeding, because the beneficial effect of the restrictive transfusion strategy with respect to the decreased incidence of rebleeding was observed mainly in their patients with portal hypertension. The authors also speculated that transfusion might impair hemostasis by counteracting the splanchnic vasoconstrictive response caused by hypovolemia, inducing an increase in splanchnic blood flow and pressure that might impair clot formation. The authors concluded that a restrictive strategy as compared with the liberal transfusion strategy improved the outcomes among patients with acute upper GI bleeding, and that the results suggest that in patients with acute upper GI bleeding, a strategy of not performing transfusion until the hemoglobin falls below 7 is a safe and effective approach. So this trial adds to the body of evidence that patients do as well, if not better, when a more conservative transfusion strategy is utilized. The final publication that I want to discuss is an updated meta-analysis of randomized controlled trials in transfused patients that was published in 2012 by the Cochrane collaboration. The Cochrane Systematic Review evaluated 19 prospective randomized controlled trials that compared high versus low hemoglobin transfusion thresholds, and this encompassed over 6,000 patients. In ICU patients, the lower hemoglobin transfusion threshold for the largest trials was 7, while in surgical patients, the lower transfusion trigger was 8, or 4 symptoms. The authors of this analysis stated that restrictive transfusion strategies did not appear to increase the rate of adverse events such as mortality, cardiac events including MI, stroke, pneumonia, or thromboembolism, did not reduce functional recovery, and did not increase hospital or ICU length of stay. The authors noted that a restrictive approach was also associated with a statistically significant reduction in hospital mortality. The investigators commented that infections were reduced in the low hemoglobin groups. Low hemoglobin thresholds were well tolerated, and that specifically a hemoglobin level of 7 was sufficient in the majority of patients. In addition, red cell transfusions were reduced by 34% in low or restrictive hemoglobin cohorts. The authors concluded that findings from this systematic review are consistent with recently published clinical practice guidelines which recommend using lower hemoglobin values between 6 and 8 as thresholds for transfusion and incorporating symptoms in a decision to initiate transfusion. The authors also noted that the existing evidence supports the use of restrictive transfusion triggers in most patients, including those with pre-existing cardiovascular disease. Insufficient data are available regarding transfusion thresholds for high-risk patients, such as patients with acute coronary syndrome or brain injury. Because there is no reason to transfuse red cells unless doing so improves outcomes, a liberal transfusion strategy that utilizes a hemoglobin transfusion trigger would be preferable only if evidence supports its superiority over a conservative approach that uses a lower hemoglobin transfusion trigger. Thus, a restrictive transfusion approach is preferable if reliable evidence demonstrates either non-inferiority or superiority compared to a liberal approach. So in summary, data from randomized controlled trials evaluating hemoglobin transfusion thresholds have demonstrated that a restrictive transfusion strategy is preferable in many clinical situations, even in very sick patients being cared for in the ICU setting. The evidence suggests that in hemodynamically stable, asymptomatic, non-bleeding patients without high-risk cardiovascular comorbidities, a hemoglobin threshold of 7 is well tolerated, can decrease transfusion requirements, and improve patient outcomes. A single-unit transfusion approach was utilized in the 2 randomized controlled trials discussed today in more detail. This strategy of transfusing 1 red cell unit followed by reevaluation of the patient's clinical status is also the recommendation offered in the Baptist Red Cell Transfusion Guidelines and is referred to as the transfuse and reassess strategy. This single-unit approach should be utilized unless the patient is experiencing significant acute hemorrhage or has profound anemia.